Hello future doctors, how are you all? Welcome back to MedSteps YouTube channel. So today in this video we are discussing very high yield topic for your exams. If you are trying to give FMGE, USMLE or NEET PG, so this topic is very important because most commonly we can see this condition, that is asthma. So in this video we are discussing what is asthma, clinical features, epidemiology, etiology and pathophysiology, and how we can diagnose this thing and how we have to manage. Okay, so I am yours Dr. Anand Jana. So this is MedSteps YouTube channel. If you didn't subscribe my channel, like, share and subscribe. Please watch this video from beginning to till end because from basic to advanced we are covering here everything. Okay, so before going to video, let's discuss one case scenario. Here you can see here a 22 years old female, like medical student, presents to the outpatient clinic with episodes of shortness of breath and wheezing and chest tightness for the past 6 months. So one 22 years old female medical student came to outpatient clinic, and here the patient have episodes of shortness of breath and chest tightness for the past 6 months. So the symptoms are worse at night and early morning and are triggered by cold air and exercise. She has a history of allergic rhinitis since childhood. Okay, so on examination her respiratory rate is 22 breaths per minute, saturation is 97% and room air. So her chest, we can see bilateral expiratory wheezes, and in spirometry it shows FEV1 68% and predicted FEV1 by FVC equal to reduced, and post bronchodilator FEV1 improves by 15% and 250 ml. So here question is, what is the most appropriate long-term controller therapy for this patient? So here we got 5 options. First of all, you have to understand this is asthma. How? Patient have allergic rhinitis since childhood. That means some allergic reactions can trigger the asthma. And asthma means the hallmark is mostly we can see like it worse at night and early morning. Okay, why? Because of triggered by cold air. So this is asthma. Now how we can manage? If you are seeing these options, you can see here salbutamol inhaler as needed only, or oral prednisolone daily, and low dose inhaled corticosteroid daily, long acting beta agonist like LABA, and monotherapy, theophylline sustained release. So if you know this answer, you can comment in this video. Okay, if you are seeing here, the answer is low dose inhaled corticosteroid daily. So I will repeat this question in end of this video because in management we have some regimens. Based on that regimens we have to treat. So before knowing about management, we have to know like basic, from basic to advanced level of the asthma. Okay, so let's go. First, introduction. In introduction, if anyone asking what is asthma? Asthma is one of the chronic inflammatory disorder of the airways characterized by obstruction or airway hyperresponsive or chronic airway inflammation. So first of all, we have to understand what is asthma. We have some bronchioles. That bronchioles have some tubes. The tubes will help to take breath in and breathe out for inhale and exhale. But in asthma, what will happen? The tubes will become inflamed. The tubes will become constricted. The tubes will secrete more amount of mucus. These 3 things we can see in asthma. First one, inflammation, bronchoconstriction and mucus secretion. It triggered by many things we will discuss meanwhile. Okay, so that's why in asthma means it's something, the bronchoconstriction or narrowing of the bronchioles because of chronic inflammatory response or inflammatory conditions we call that is asthma. Okay, So epidemiology, if you're seeing here, mostly this asthma we can see in children's pediatric disease. It can present at any age, but most common in pediatrics. The risk factors will be like atopy, strongest identification factors, and atopic dermatitis. That means it's like with allergic reactions or because of histamines, because of hypersensitivity, we can see asthma. Next one, food allergies, maybe because of peanut allergy or pollen grains or any fish allergy can cause asthma related things. Next, allergic rhinitis and family history. If any patient have, while okay, if, for example, one child came to you and the child have asthma, how you find out that asthma means? We have to know the family history. In their family anyone have asthma, then that means same to same, whenever the child, maybe if premature baby, or if mother have family history, or in home if anyone have allergic reactions or smokers, this type of conditions can cause asthma. So smokers and obesity and air pollution. So these are the epidemiology. Okay, so and these are the triggers also. So next one, asthma. If you are seeing this image, you can see here these bronchioles are normal. So it's the bronchiole will be like very wide. Okay, if you are seeing next one, if you can see here the bronchiole become like wide and it's narrowing that lumen. Whenever that lumen getting narrowed, the oxygen, like inspiration, patient will not get any problem, but in expiration patient will get problem. That's why we can see respiratory acidosis in asthma problems. Okay, so that's why asthma means inflamed bronchial tube. So pathophysiology, I already discussed about asthma. Asthma is defined as airway hyper-responsive because of allergic reactions, and it's causing variable and reversible airflow. So asthma is the reversible obstruction. Okay, so whenever patient getting asthma, easily it can be reversible. Okay, next one, in pathophysiology we can see genetic factors. In genetic factors we can see HLA gene mutation, it defects in bronchial airway epithelium. So it's like genetic factors also can cause asthma. Next one, environmental factors, like maybe because of excess hygiene, fever, siblings and antibiotics within the first 2 years. These are the things can cause atopy, and it's like we can see predisposing to allergic hypersensitivity in airways. The first exposure to triggers to sensitizes helper T cells. So here it stimulates of beta cells and it produces IgE, means allergic reactions. IgE will produce and which binds to mast cell surfaces. And here we have some second exposure triggers, that is like early response and delayed response. In early response we can see 0 to 2 hours. Here the allergens, the cross links IgE and mast cells. Mast cells means it's like macrophages. The mast cells releases histamines, that is the main histamine, and leukotrienes and other inflammatory mediators will cause airway obstruction. How? These are the things will increase vascular permeability and edema of airway mucosa, and goblet cells will increase, and the goblet cells will secrete more amount of mucus. The thing we called hyperplasia, and increases mucus secretion, and the bronchial smooth muscle will become contract. So these are the things will cause airway obstruction and it will cause asthma. Next one, delayed response. In delayed response we can see like 3 to 4 hours. Why it's getting delayed means it's activating mast cells and helper T cells and releases cytokines. Next one, it induces maturation of granular white blood cells like eosinophils. So that eosinophils will migrate to airways and eyes and nose. Whenever it's migrating to airways, it will cause bronchial constriction. Whenever it's going to eye, it will cause conjunctivitis. Whenever it is going to nose, it will cause rhinitis. So these are the things will cause, we call allergic rhinitis. It will cause asthma. So this is like step by step approach we can see in pathophysiology of asthma. So here the delayed response, it presents within 3 to 4 hours and it speaks within 6 to 8 hours and it will resolve within 24 hours. Okay, so this is the pathophysiology of the asthma. So triggers, what are the triggers you can see? The airway getting hyper responsive, it includes like upper respiratory tract infections. This is most common one. Next one, allergens like pollen grains, animals, danders, like dog, like hair. Okay, and if anyone not cleaning that mats and everything, curtains in home, it will cause a dust or mold, etc. In air pollutions like cigarette, smoking and other chemicals also can cause asthma. It will act like triggers. Next one, drugs. Some drugs can cause asthma like aspirin, NSAIDs, non-steroidal anti-inflammatory drugs, or beta blockers also can trigger, can increase the asthma condition. Okay, next one, cold air and like exacerbation exercise. So these are the triggers of asthma and pathophysiology. So next one, you can see this image. This is normal airway and this one asthmatic airway, because whenever patient getting asthma, that lumen will become narrow and the bronchial will secretes more amount of secretions. So next one, asthmatic airway during attack. Whenever patient getting acute asthma attack, the bronchial will become too much narrow and it will cause breathing exacerbation and persistent shortness of breath, chest pain and wheezing. These are the things we can see in patient. Okay, so clinical features. What are the clinical features you can see means, you can see this picture here. Whenever patient getting asthma, the common wheezing, shortness of breath, chest tightness or cough. This is the most common clinical features. When it's like very severe, when we can find out means, if patient have red flags. Red flags means inability to speak like full sentence. They will do whispering, they will do same to same like this. Okay, next one, silent chest, use of accessory muscles and cyanosis. In cyanosis, like blue in color, like in child means we have to focus on this sternum and lips and chest area. Okay, that become like blue in color and fingertips. This everything you have to focus. In like adult or old age means you have to check saturation less than 90%, that is the red flag of asthma, and peak expiratory flow will be like less than 33% if you are predicted. Next one, altered mental status. So these are the things you can see in clinical features of asthma. Next one, asthma classified into 4 different categories. The severity of asthma. How? So first one, intermittent severity. Intermittent asthma means the patient must be, the symptom frequency will be like less than equal to 2 days per week. Means weekly 2 times we have to see that's asthmatic episodes like shortness of breath and this type of things. Less than 2 nights got difficulty per month. Okay, whenever you are doing pulmonary function test, in that pulmonary function test we can see FEV1 like greater than 80% of predicted. Then you have to think that is intermittent like asthma. Okay, next one, mild persistent asthma. In mild persistent asthma, you can see like greater than 2 episodes per week but less than 1 per day. So, and next one, greater than 2 nights per month. So in pulmonary function test you can find out like FEV1 greater than equal to 80% of predicted. Okay, so this is mild persistent. Next one, moderate persistent. In moderate persistent you can see like daily daytime like greater than 1 night per week. And predicted level pulmonary function test is FEV1 60 to 80% of predicted. So next one, severe persistent asthma. In severe persistent asthma we can see like it's like continually the patient getting shortness of breath and asthmatic attack. it's like continual daytime, and frequently we can see in night time also. So the pulmonary function test, the FEV1, we can see like less than 60% of predicted. So this is the classification. Now investigation. Whenever you are seeing for asthmatic investigation, what are the things we can do means, first one, imaging. In imaging, the chest x-ray will be like normal. You can see some infiltrates, but mostly the lung will get hyper inflated and some little infiltrates you can see, but asthma x-ray will be like normal. Okay, the patient will comes with shortness of breath clinical features and the chest pain, and patient will get more amount of using accessory muscles and the diaphoresis. This type of patient will come with this type of conditions, but the chest x-ray will be normal. So next one, and other investigations we can do. First one, the gold standard test is pulmonary function test. The pulmonary function test, that is the gold standard. Next one, peak expiratory flow rate. It can be used at home to monitor obstruction, and less than 50% of personnel best indicates a severe obstruction. Next one, we can do arterial blood gas. In arterial blood gas, we can see the patient, if any patient have mild hypoxia, if you are checking arterial blood gas, in that arterial blood gas, the respiratory alkalosis you can see because of tachypnea, and if patient have normalized, the partial carbon dioxide will indicate, and it will cause fatigue and impediment and respiratory failure. So in severe cases, we can see respiratory acidosis due to carbon dioxide is not going out and the carbon dioxide is present inside the lungs. Okay, thing is, the patient will get problem with expiratory of the like exhale. In inhalation, the patient will not get any problem in asthma. So the diffusion capacity of carbon monoxide, that is normal. So now management, this is the main thing and main important thing. That is, whenever we are discussing about any pathological condition, we have to divide that management into two different types. First one, non-pharmacological management, next one, pharmacological management. So now we are going to discuss about non-pharmacological management. That is, we have to do lifestyle and prevention, lifestyle modification and prevention. Next one, we have to know the triggers and we have to try to avoid or try to reduce the things. Next one, if patient doing any smoking, we have to advise to quit the smoking cessation, and allergens control, that is like dust covers, pets and this type of things, and exercise. Like if any patient doing aerobic exercise, within the patient have to understand that body condition, then they have to do exercise. Next one, vaccinations. In vaccinations, if pediatrics means, always this vaccination is very important for asthmatic patient. Like influenza, in early cases, pneumococcal, it will be like very high risk causing asthma. So the patient must be vaccinated. Next one, education. We have to give education about how to use that inhaler, whenever patient taking inhaler, what they have to do, the steps we have to teach the patient how to do properly that inhalation. Next one, we have to advise to maintain one diary for asthmatic episodes. Whenever the patient using the diary, whenever they are coming to clinic, so easily we can find out what type of that classification of the asthma. So based on that, we can treat the patient. Okay, so now pharmacological management. In pharmacological management, based on that classification, we are going to treat. First one, mild asthma. So in mild asthma, if symptoms like less than 2 times per month, then we have to do low dose of inhaler corticosteroids with formoterol, and we have to avoid short acting beta agonist drugs like salmeterol and this type of things. In mild persistent, the symptoms greater than 2 times per month, and the best options is daily low dose of inhaler corticosteroids we have to give. This is the main thing, because the patient, when we discussed about case scenario, in that case scenario, that medical student, 22 years old medical student got like that, like a breathing problem, everything that worsening in night time. Okay, so that's why in mild persistent the low dose of inhaler corticosteroid is we have to give, or we can add inhaler corticosteroids with formoterol. So next one, moderate asthma. In moderate asthma, the low dose of inhaled corticosteroid with long acting beta agonist we can give, like example budesonide or formoterol or fluticasone or salmeterol. So these are the things we can give. Next one, severe asthma. In severe asthma, medium to high dose of inhaled corticosteroid with LABA, long acting beta agonist like albuterol, okay, and formoterol. These are the things we can give. We can add like tiotropium like LAMA and or montelukast. If it's like severe cases, then we have to use this thing. If patient getting like refractory asthma, like biological therapy we have to give, like omalizumab or mepolizumab and oral steroids. This is the last options of oral steroids. So in pharmacological management, the step-by-step approach, if any patient coming with acute asthma attack, first of all we have to treat with oxygen. In oxygen also, based on patient condition, based on saturation. If patient coming means we can provide oxygen mask, nasal prongs, or sometimes dual oxygen therapy also we can provide. Next one, nebulization. Then after nebulization with salbutamol, like salbutamol 2.5 to 3 milligram we can give, or 2.5 to 5 milligram we can give salbutamol for nebulization. Next one, oral or intravenous steroids. So for example, we are giving hydrocortisone. Hydrocortisone we can give 100 milligram we can give intravenous hydrocortisone every 6 hours. Next one, if you are giving, then after oral or intravenous steroids we can give. Next one, if patient getting severe asthma attack, for that patient we can give oxygen supplementation. Next one, we can give salbutamol and ipratropium. Next one, intravenous hydrocortisone. I already told the dosage. Next one, intravenous magnesium sulfate, like 2 grams intravenous. If patient getting like severe, after using this medication, after using steroids like prednisolone, like 40 to 50 milligram, after using these things also, the patient is not getting any recovery, then the patient, we have to think about status asthmaticus. Then we have to send that patient to ICU for other management. Okay, so these are the things. So here today in this video we discussed about asthma. We discussed about some little like case scenario and what is asthma and epidemiology and asthma inflamed bronchial tubes. Next one, pathophysiology. Next one, clinical features and asthma classification, investigation imaging and other tests. Next one, like in management, non-pharmacological management and pharmacological management. So these are the things. If you have any doubt, you can ask me in the comment section. If you want to discuss any other topic, you can ask me in comment section. So based on that I will give reply. So same to same like this we will discuss every day some topics. So if you didn't subscribe my channel, like, share and subscribe. So let's meet in our next video. Till the time, take care. Bye bye.